Good morning. Today we're going to discuss the treatment of inflammatory processes, including gout and anti-gout and ergogenic agents, corticosteroids, non-steroidal anti-inflammatory drugs, as well as aspirin and non-salicylates. In addition, we're going to discuss the treatment of adrenal insufficiency, as well as many other disorders. So let's start with gout. If you recall, in pathophysiology, gout is no more than the precipitation of monosodium urate crystals into the tissue. And it's usually happening around the joints, but most often causes recurrent acute and chronic arthritis. This is an arthritis related to alteration of the purine metabolism, leading to increase of uric acid. The initial attack of acute arthritis is usually monoarticular, and if you recall, is called pedagra because most likely involved the first metatarsophalangeal joint or the great toe, giving acute pain, tenderness, warm, redness, and swelling. If you recall, the diagnosis is require isolation or identification of crystals in the synovial fluid. And basically the treatment is anti-inflammatory as first line that you would see that includes NSAIDs and colchicine, but also for prevention and maintenance you could give medications that lowers the serum urate level, such as allopurinol, febuxostat, and uricosurics. Again, to give a brief summary, in the pathophysiology, the greater the degree of duration of hyperuricemia, the greater is the likelihood of the gout attack. Urate levels can be elevated because one, decreased excretion, which is the most common cause of gout, increased production of uric acid, as well as increased purine intake. So in the decreased renal excretion is by far the most common cause of hyperuricemia. It could be hereditary, it could be congenital. Also occurs in patients receiving diuretics, those with diseases with decreased glomerular filtration rates, such as in renal failure, patients that have high consumptions of alcohol, because alcohol increases purine catabolism in the liver and increases the formation of lactic acid, which at the same time blocks urate secretion by the renal tubules of the kidney. So alcohol may also stimulate liver urate synthesis. Uh, Lead poisoning is another cause of decreased renal excretion. So in essence, any cause that could produce damage of the renal tubules or excretion of the uric acid. For the increased production, that may be caused by any hematological cancer due to cell turnover, such as lymphoma, leukemias, hemolytic anemias, patients that have autoimmune diseases such as psoriasis, or patients that have gone through radiation therapy or chemotherapy. Um, it could also occur by congenital patients that um, have deficiency of hypoxanthine metabolism, um, increased intake. Besides the alcohol that we already mentioned, that is part of the cause of decreased renal excretion, patients that take purine-rich foods such as organs, liver, kidney, anchovies, asparagus, consomme, which is basically chicken broth or beef broth, meat gravies, mushrooms, mussels, sardines. They could all contribute to hyperuricemia. Urate precipitates as needle-shaped monosodium urate crystals deposited in the avascular tissue, which is the cartilage, and also tendons and ligaments, as well as bursas. Um, it could also be deposited in the skin around distal joints, such as in the ears. And this is the one that produces all the symptomatology. Acute arthritis could also be precipitated or triggered by other systemic conditions. Patients that suffer gout when they have a trauma or when they have any medical stress, such as pneumonia or other type of infection, patients that have gone through surgery recently, or patients that are on thiazide diuretics, could have an acute event of gout. So there are phases related to gout. You have asymptomatic hyperuricemia, you have acute gouty arthritis, you have an intracritical gout that also the patient is asymptomatic, and a chronic tophaceous gout. The most likely presentation of acute gout is sudden onset of pain, most likely nocturnal. The metatarsal phalangeal joint, which is the great toe, is the one that most often involved. It's called podagra. But it can also take the ankle, the knee, the wrist, the elbow, rarely the hip or the shoulder or cervical spine. The pain becomes progressively more severe, usually over a few hours, and is excruciating. It's associated with swelling, warm redness, and exquisite tenderness that could suggest infection. The overlying skin could be tense, warm, shiny, purple or red. Patients could have fever, tachycardia, chills, or even malaise. So the course of the disease, as I said, the first few attacks usually affect only one joint. Later attacks may affect several joints simultaneously. Tophi could also develop most often in patients with chronic gout, but they can rarely occur in patients who have never had a gout attack. The diagnosis, as you say, is, as we already said, there is actually a clinical criteria based on the symptoms of acute monoarticular or oligoarticular arthritis, which is less than 3 joints. Podagra and recurrent inflammation are particularly suggestive of the disease. Previous attack that began explosively and resolved spontaneously are characteristic. And of course, the isolation of the urate crystals in the synovium. You could do synovial fluid analysis and by arthrocentesis, and basically isolating the urate crystals, monosodium urate. You could also do serum urate level to support the diagnosis, but it's neither specific nor sensitive. You could do x-rays of the affected joint that may be taken to look for bony tophi, but are probably unnecessary if the diagnosis has been established by synovial fluid analysis. The treatment, let's discuss. For termination of an acute attack, you need to have in mind that the only medications for acute attack are non-steroidal anti-inflammatories, corticosteroids, and colchicine. Even though the PowerPoint will start to combine all the medications, I need you to remember that for any time the patient has an acute gouty attack, NSAIDs, corticosteroids, or colchicine. Now, for prevention of recurrent acute attacks or for prevention of further deposition of urate crystals and reduction in flare incidence, or even the resolution of existing tophi, you could use, besides NSAID and colchicine, you could use allopurinol, febusoxate, probenecid, or sulfapirazine. Now, in addition, you have to have in mind that you need to treat underlying conditions. If it was related to trauma, if it was related to sepsis. So any disease process that lead to an acute gouty attack has to be also managed. Try to treat coexisting hypertension, hyperlipidemia, obesity, and avoidance of excess of dietary purine, of course. So, anti-gout drugs to reduce the inflammation or to prevent the synthesis of uric acid, you have them listed, but do not forget that medications to treat acute gouty attack are only your NSAIDs, your colchicine, and corticosteroids. Now, there's also uricosurics. You have probenecid and you have sulfentrazone. This is etofide with the podagra. You see the redness and the warm, of course, by touch of the joint. Now, foods that contain high levels of purine are anchovies, mushrooms, asparagus, organs, alcohol, as we already explained. Now, let's start one by one with the mechanism of action. You have allopurinol that acts directly on purine metabolism by reducing the production of uric acid. Febuxostat inhibits xanthine oxidase that, if you recall, the purine metabolism refers to the metabolic pathway to synthesize and break down purines that are present in many organisms. So xanthine oxidase is the one that basically avoids the production of uric acid when you inhibit that, of course. So you also have colchicine that colchicine basically inhibits migration of granulocytes and it acts as an anti-inflammatory, and again is one of the main medications for acute gouty attack. It's basically a natural product. It's secondary to plants. The medical uses is an alternative for those unable to tolerate non-steroidal anti-inflammatory drugs such as Motrin or Advil or Aleve. So if the patients cannot tolerate that or they're allergic to NSAIDs or they have a major GI distress, you could give them colchicine. Now, of course, at high dosages, colchicine can also give a GI distress. But it's a potent anti-inflammatory. So talking about the metabolism, what happens in gout is that once an attack starts and these monosodium crystals are formed, the white blood cells are attacked and they release proteins. And these proteins attached to the white blood cells producing an activation of the inflammatory pathway, lowering the pH of the synovium and allowing more monosodium crystals to precipitate. Uricosuric medications such as probenecid and sulfentrazone, they are not anti-inflammatory. They do not have any anti-inflammatory activity. They are not used for an acute attack. Basically, probenecid inhibits renal tubular reabsorption of urate, and if you recall, also it is good for the tubular secretion of penicillins or cephalosporins. So it is used for gout because it inhibits tubular reabsorption of urate and increasing uric acid secretion, and it's also good as a coadjuvant for many infectious diseases when you're planning to treat the patient with long-term penicillins or cephalosporin, because it inhibits tubular secretion of penicillins and cephalosporin, increasing the half-life of those. Sulfentrazone is also an uricosuric. Inhibits renal tubular reabsorption of urate and also is a competitive inhibitor of platelet aggregation and prostaglandin synthesis. So it does have a weak anti-inflammatory activity, but is not used for acute gout episodes. So all gout drugs are well absorbed orally. Probenecid and sulfoperazone are highly protein bounded. So remember the properties of this. Um, Metabolized in the liver and excreted in the urine. So the precautions on contraindication, all these drugs must be used cautiously when the patient have renal failure as well as liver failure, because allopurinol and colchicine could cause hepatotoxicity. Colchicine, probenecid, and sulfoperazone uh, should be used in patients cautiously when they have peptic ulcer disease, because remember, even though colchicine is one of the best choices when the patients cannot tolerate NSAID, at higher dosages they also could produce GI distress. For pregnancy, probenecid is the only one that is a category B. Um, the rest are either C or D. Besides prophylactic treatment and avoidance of high uric acid containing or purine containing food, and eliminate the underlying disease, as well as the treatment for acute gouty attack or prevention, the patient should have a high intake of fluids to be able to excrete the uric acid. And also you could provide alkalization of the urine by administered sodium bicarbonate or potassium citrate. Be aware of possible GI distress um, with high doses of colchicine, probenecid, sulfoperazone, and also NSAIDs. Colchicine can also cause significant diarrhea. Have in mind that mostly sulfoperazone have a sulfa-based drug, so if the patient is allergic to sulfa, they should not take this medication. Colchicine could develop myopathies and weakness, and also could cause vitamin B12 deficiency. A lot of drug and drug interaction because of high protein bounding. As you recall, that could be highly asked questions on exams on boards, that probenecid inhibit tubular secretion of penicillin and cephalosporin, and this is the reason why it's a adjuvant treatment for many infectious diseases when you're planning to treat with penicillin or cephalosporin. Sulfoperazone is an uricosuric, reduces renal secretion and displaces the bound protein, so it will decrease the inactive drug in plasma. Remember that any times medication is a xanthine oxidase inhibitor, it could compete with other medications that have the same mechanism of action, for example, theophylline in asthma, and this could create toxicity. Now, for acute gouty attack, I cannot emphasize more that patients should be only on either NSAIDs, colchicine, or corticosteroids for acute attack. So for colchicine, you have to start at the first sign of gout flare. Start with a low dose and then increase later as the pain improves. There's also preventative dosage, because remember, colchicine can also be used to reduce the flare attacks or intracritical gout. You give a lower dosage. For acute attack is 1.2 and for prevention is 0.6. There's also off-label uses of colchicine such as hepatic cirrhosis, biliary cirrhosis, and also scleroderma and ITP. Now, for prevention, you could use allopurinol, you could use sulfoperazone. For allopurinol, is also an off-label use besides gouty attack for the prevention of urinary calculi in patients that have had pyelonephritis event calculus. It's also used for hyperuricemia associated with malignancies. If you remember, in pathophysiology, there is a syndrome called tumor lysis syndrome, which is basically a rapid turnover cell results in release of intracellular content in the circulation um, that basically overwhelms renal elimination of the cellular buffering mechanisms. Um, Patients would have uh, several alterations of electrolyte. Um, this could occur spontaneously, but it's most likely produced by chemotherapies and radiation therapies. Um, Hyperkalemia is often the earliest laboratory manifestation, but patients could have also hyperphosphatemia, hypocalcemia, and hyperuricemia and renal failure. Febuxostat is also used for chronic gout and for maintenance and prophylaxis in patients with hyperuricemia. You start basically 40 milligrams per day and then increase to 80 milligrams per day when the serum uric acid is less than 6 after 2 weeks. Of course, you have to monitor renal function, uric acid levels, and liver function. It could also cause an acute gout flare. So that's the reason why you could combine this medication with NSAIDs or colchicine during the first 6 months of therapy. Gout with a pathophysiology of overproduction of uric acid, you could use probenecid. So once the acute attack has resolved, you could start probenecid as well. Start at low dosages and gradually increase. After 6 months, if you're higher than 500 milligrams, so reduce to 500 milligrams every 6 months, and of course monitor uric acid level. Sulfaperazone, the usual dose is 200 to 400 milligrams BID. It does cause GI stress, so you have to take it with food, and may also cause platelet dysfunction. Again, I can't emphasize more. Colchicine is used for acute attack as well as NSAIDs and corticosteroids. Allopurinol or febuxostat is best for patients with overproduction of uric acid. If the patient has renal failure, best allopurinol. If there is no problem with renal function and the patient main problem is under secretion of uric acid, you could use probenecid. Allopurinol is the drug of choice with high uric acid and secondary gout due to trauma, sepsis, burns, etc. Sulfaperazone is the best for patients who undersecrete uric acid when on regular diet and those who need antiplatelet activity. So monitor serum uric acid level, of course. You could do one baseline and after 1 to 3 weeks of therapy, then periodically. For allopurinol, monitor liver function test, renal function test, as well as, of course, uric acid. For probenecid and sulfaperazone, remember that it could produce a decrease of platelet because it has an antiplatelet activity, so you could monitor CBC for blood dyscrasias. This is again an algorithm how these medications work. Okay, again, if you look, always try to reduce any type of food that contains purine, high levels that could alter the metabolism. Um, in addition, allopurinol blocks formation of uric acid. Uricase, which is an uricosuric, breaks down the uric acid. Probenecid increases excretion of uric acid in the urine. And NSAIDs, colchicine, and corticosteroids, these three are the one that you're going to use for acute gouty attack, reduces the degree of inflammation. So take the medication exactly as prescribed, never discontinue without consulting. Do not stop preventative medication during acute attack. Do not take aspirin if the patient is on probenecid or sulfaperazone because it could produce more antiplatelet activity. GI upset, hypersensitivity. Remember sulfaperazone for sulfa allergic drugs patients. Monitor for rash, myopathies, and neuropathies. Remember that increase fluid intake, you could alkalinize the urine as well as the diet and avoid alcohol. Now let's talk about adrenal gland. Remember that the adrenal gland has the cortex and the medulla. In the cortex, there is secretion of glucocorticoids, which is cortisol, mineralocorticoids, which are aldosterone, and androgens, which is testosterone. For the medulla, there's a secretion and production of epinephrine and norepinephrine, which are the catecholamines for fight and flight. Now, what are the main functions of steroids? Glucocorticoids in the adrenal cortex. If you recall the disease process called Cushing's syndrome or Cushing's disease, which is a constellation of clinical abnormalities caused by chronic high blood levels of cortisol and related corticosteroids, you will remember all the effects that any type of glucocorticoid will have. Remember that there's a hyperfunction of the adrenal cortex by either hypersecretion or exogenous administration, or a pituitary tumor, or even a small cell carcinoma of the lung that could produce Cushing's syndrome. Basically, all the clinical manifestations are by excess of glucocorticosteroids that you would see here. How do they manifest? By facial moon face, plethoric appearance, truncal obesity, buffalo hump due to prominent supraclavicular and dorsal cervical fat, very slender distal extremities and finger, muscle wasting and weakness. The skin is atrophy and poor wound healing and easy bruising. Patients would have purpura striae, mostly in the abdomen, hypertension, renal calculi, osteoporosis, glucose intolerance, reduced resistance to infection, mental disturbances. Also, females could have menstrual irregularities, hypertrichosis, as well as temporal balding or any other signs of virilism. So the functions of the glucocorticoids is to maintain glucose control. So if you have glucocorticoid excess, the patients would have hyperglycemia. If there is glucocorticoid deficiency, such as in adrenal insufficiency or Addison's disease, would be hypoglycemia. Since it's in charge of suppressing immune response, if there's an excess or deficit of glucocorticosteroids, the patients could have alterations of the immune system, autoimmune diseases, or even infectious process. Help the body respond to stress, maintains blood pressure and cardiac function, so patients would have either hypervolemia and hypertension in Cushing's, or hypotension and bradycardia in Addison's disease. It's also in charge of secretion of mineralocorticoids, which are aldosterone, that regulates sodium and potassium balance. So if the patient has an excess of glucocorticoid and mineralocorticoids, they would have retention of sodium and excretion of potassium, so hypernatremia and hypokalemia. In the contrary, in Addison's disease would be hyponatremia and hyperkalemia. There's also affects sexual dysfunction. Patients with either hypercortisolism, Cushing, or hypocortisolism, Addison's disease, they would have sexual dysfunction and either increase or decrease sexual drive. And menstrual irregularities. It does maintain level of awareness and sleep pattern, so the patients would have either insomnia or hypersomnia. Labile emotions, stimulates gluconeogenesis. So again, if it's elevated by Cushing's, hyperglycemia, otherwise hypoglycemia. Stimulates protein catabolism. So you would see the patients with Cushing maldistribution of proteins and fat. And in Addison's disease, of course, for Cushing, buffalo humps. And increased fat deposits, maldistributed, or in Addison's disease, the patients would be decreased extremities and also cachexia. Um, Poor healing in Cushing's as well as alteration in Addison's disease. If you recall, this is the axis of a hypothalamus pituitary axis for adrenal cortex and medulla. There is if there is a decrease of cortisol level, there is a positive feedback sent to the hypothalamus to start releasing cortico tropic hormone and cortisol. And if there's an excess of cortisol, such as in Cushing, there's a negative feedback sent back to the hypothalamus to decrease corticotropin releasing hormone as well as adrenal corticotropic hormone. So again, the actions are to inhibit immune and inflammatory systems, so decreases proliferation of T lymphocytes as well as natural killer cell. So the patients could have alterations in immune system not defending themselves properly for infection. Increased circulating erythrocytes, so patients could have polycythemia in Cushing's and anemia in Addison's disease, increased appetite and obesity in Cushing, and decreased appetite and cachexia due to increased catabolism in Addison's disease. Promote fat deposits in the face and cervical area. So if it's Cushing, there's maldistribution and buffalo hump, and this does not happen in Addison's disease. Promote lipolysis in extremities. So this is the reason why the um, extremities are thin in these patients compared to the trunk. Increased uric acid excretion, so patients with Cushing syndrome could also have gout and hyperuricemia. Decreased serum calcium level, hypocalcemia, as well as hypercalcemia. So hypocalcemia for Cushing, hypercalcemia for Addison's. Promote gastric acid secretion, so patients could have GI distress and gastritis and peptic ulcer disease in Cushing and backwards in Addison's disease, so and so on. So this is basically a refreshment for pathophysiology. You have all the manifestations if a patient would have a Cushing syndrome. Now, aldosterone, remember that the main function is retention of sodium and water and excretion of potassium. This is the renin-angiotensin-aldosterone system. Remember that whenever there is increased blood volume or pressure, there is a release of, first, catecholamines to increase vasoconstriction and try to bring volume and pressure back. If this does not improve, then renin is released by the juxtaglomerular apparatus of the kidneys that provides the conversion of angiotensin, the release of angiotensin, and angiotensin 1 conversion to angiotensin 2 is triggered by the release of angiotensin converting enzyme that causes the vasoconstriction as well as increasing cardiac output to increase blood volume and pressure. Also decreases glomerular filtration rate, resulting in water retention, as well as patient will increase thirst to bring more volume into the vascular space. Remember that if this does not improve volume and pressure, then there is release of vasopressin as well. So aldosterone will cause nephrons to reabsorb more sodium and water, and antidiuretic hormone will also be released that mediates the insertion of aquaporins into the collecting duct for more reabsorption of volume into the blood, as well as increasing sodium reabsorption in the medulla. So all the corticosteroids, they're well absorbed in the GI tract. They're metabolized by the liver. Cortisone is converted into hydrocortisone, and prednisone is converted to prednisolone. They're all excreted by the kidney. They're contraindicated, and this is very important. They're all contraindicated in patients that have active untreated infections. So if you have a patient with sepsis, if you have a patient with any major infectious process, at least until the patient is getting better, never introduced high levels of corticosteroids or at all, unless you believe that the sepsis is producing adrenal insufficiency and refractory hypotension due to that. So you have to be very cautious with patients that have uncontrolled hypertension and cardiovascular disorder, because the major purpose of this is to bring volume into the vascularity, so it could elevate blood pressure and it could retain as water as well as increase potassium. Be very cautious with patients that are postmenopause due to osteoporosis, uh, hyperglycemia in diabetic patients, as well as any type of GI upset or perforation, or even increased gastritis and peptic ulcer disease in patients that already have an autoimmune disorder such as ulcerative colitis and Crohn's disease. They could produce atrophy and thinning, so be very attentive and educate the patients of possible striatum, hirsutism, and poor healing. So if a patient, for example, just recently had a surgery, you would never start the patient on steroids because of poor healing. So imagine a patient, for example, with a coronary artery bypass graft, and introducing steroids due to, for example, bronchospasm. You could dehisce the wound, and it could produce an infectious process. Truncal obesity, buffalo humps, as we explained already. It could also produce cataracts and glaucoma, as well as peptic ulcer disease. For cardiovascular, remember fluid retention, electrolyte imbalances because of aldosterone. It could produce hypernatremia and hypokalemia, hypertension. For central nervous system, remember that all the steroids could agitate the patient. They could go into delirium, confusion, aggressiveness, and even severe depression. For endocrine system, it could produce adrenal suppression, withdrawal syndrome, that it could be happening if you abruptly stopped these steroids. So if a patient has been more than a week on, actually more than 3 days, on high levels of steroids, you never discontinue abruptly. You should start tapering down. Now, for adrenal insufficiency that we basically already explained, in contrast with Cushing, you will you will give corticosteroids, and that's basically one of the treatment of choice, either for replacement, for inflammatory process, or to deplete the immune system in case, for example, the patient has an autoimmune disorder. So the drug of choice are hydrocortisone, cortisone, and prednisone. You have here the dosages. For example, hydrocortisone will be 50 milligrams every 8 hours for 48 hours, and then start tapering down. Cortisone, 25 to 300 milligrams BID, and then start tapering down. Prednisone, 5 to 60 milligram BID, and always try to mimic the circadian rhythm. Remember that the highest levels of corticosteroids released by the adrenal cortex naturally and physiologic are in the morning. That's the highest peak, and that starts tapering down more or less around 3 p.m. and go to the lowest level more or less at 6 p.m. So try to give the first dose in the morning at 9 o'clock. So again, what are the indications for corticosteroids? Either for inflammation, for replacement in case of adrenal insufficiency, immunosuppression, and you give it for, of course, in autoimmune diseases such as rheumatoid arthritis. So for inflammatory conditions, you would give methylprednisolone, which is solomedrol, prednisone, triamcinolone, or dexamethasone. So the one that are mostly used are solomedrol in the hospital, dexamethasone in the hospital, and prednisone and triamcinolone outpatient. For immunosuppression, prednisone is used for its short half-life. They're also different strength. For rheumatoid arthritis, you also use prednisone, but again, you could use NSAIDs and disease-modified rheumatoid factors, as we will see, and always use prophylactic with biphosphonates for osteoporosis with calcium and vitamin D. Now again, as I already explained, try to best match the natural circadian rhythm. So try to give the dosages of steroid in the morning. Patients will get less confused if you do so, because they would not have insomnia, and the alteration of behavior and neural component will be less. The initial dose basically depends on what do you want to treat, if it's inflammation, if it's replacement, or if it's immunosuppression. So adjust the dose according to that. So try to determine the maintenance dose, and try to start tapering down once the patient acute illness has subsided. If after long-term therapy or because of spontaneous remission, the drug is to be stopped, again, taper off. Never discontinue abruptly if it has been used for more than 3 days. Most conditions that require chronic corticosteroids can be well tolerated on alternative days. So you could do twice the daily dose and it's given every other morning, 9 o'clock. Unlike a tapering schedule, alternative day schedule also retains the same total steroid dose. So you could either choose tapering or alternative days. Now, the length of therapeutic. Short-acting agents are less likely to produce HPA axis suppression, and long-acting agents are preferred. So when of course you're trying to give a high dose. Long-acting agents such as solumedrol, which is methylprednisolone, and dexamethasone, you could use high dosages, and this is mostly used in hospitals in acute illnesses. And short-acting such as prednisone, even though they're less likely to produce HPA axis suppression. If you have a patient with long-term use of prednisone, you will never discontinue abruptly because it could produce adrenal insufficiency. So monitor weight and electrolytes, glucose, CVC, lipids, as well as possible GI bleed. And remember eye exams for cataracts and glaucoma. So again, take exactly as prescribed. Explain the patient that never discontinue the medication abruptly, that is either tapered down or used as alternative day to avoid adrenal insufficiency and refractory hypotension and even coma. Major side effects at any sign of infectious process, consult a practitioner or go to the closest emergency room or urgent care. Because of immunosuppression, it could produce GI bleed, non-healing sores, changes in body habits, and also mood changes. You need to tell the patient that it's important to use a medic bracelet if this is a long-term use of corticosteroids, because if the patient is found unconscious on the street and nobody knows that the patient is steroid dependent, once the patient is admitted, and it will be off abruptly of prednisone, and the likelihood for hypotensive shock. Monitor electrolyte imbalances and also caloric management. Assess any type of GI bleeding, peptic ulcer disease. Try to avoid non-steroidal anti-inflammatory in conjunction with steroids because it increases the likelihood for GI bleed. Now let's talk about the arachidonic acid pathway. Remember that this is basically a prostanoid pathway that produces cyclooxygenase as well as lipooxygenase. There are different forms of cyclooxygenase enzyme. There's a COX-1 and a COX-2. Aspirin and other non-steroidal anti-inflammatory drugs such as ibuprofen are non-selective inhibitors of COX enzyme. Um, NSAIDs are relatively selective for COX-2, and generally, even though they do have the possibility to have fewer gastrointestinal related side effects. Um, COX-1 constitute prostanoid under basal conditions. COX-2 is inducible and up-related during inflammation. Smooth muscle cells in blood cells produce prostaglandin, and prostaglandin generally acts as a vasodilator. Um, Vascular endothelium produces prostaglandin. There's also thromboxane A2 that is released by leukocytes. So cyclooxygenase will produce prostaglandin, will control temperature, control inflammation, control pain, as well as there's lipooxygenase that also controls the possibility of bronchospasm. So NSAIDs will inhibit the COX pathway. You have prostaglandins that are produced by the body to promote inflammation, pain, fever, and also supports clotting. It does help protect the lining of the stomach and also digestive axis. Um, Again, as I said, encourage the production of prostaglandin, um, which can help relieve inflammation and pain. So there is non-steroidal anti-inflammatory drugs that inhibit cyclooxygenase, either COX-1 or COX-2 activity, by, of course, inhibiting prostaglandin synthesis. So that's the mechanism of action of non-steroidal anti-inflammatory drugs, which is, again, prostaglandin synthesis inhibition and cyclooxygenase inhibition. COX-1, as you recall in pathophysiology, is present in all tissue cells, platelets, endothelium, GI tract, renal vasculature, glomeruli, and collecting tubes. So if you use a COX-1 inhibitor, it would give you more GI distress. COX-2 is an inducible enzyme that is synthesized mainly in the macrophages, response to pain and inflammation. So if you inhibit COX-2, would give you less GI distress. Tylenol, the mechanism of action is not well known, but it's also thought that inhibits central and peripheral prostaglandin synthesis. It's used as an analgesic and an antipyretic, reduces fever, reduces pain as well. It does not have any effect on the cyclooxygenase pathway. So the absorption is very rapidly after oral administration. NSAIDs are metabolized by the liver and excreted in urine. And remember that prostaglandins are essential in the post-renal arteriole as a compensatory mechanism of the kidney when there is low volume. So any patient that has hypovolemia and acute renal failure due to pre-renal nature, you should avoid NSAIDs. Hold them to allow the kidney to compensate. Tylenol is metabolized by the liver, but it could produce hepatic necrosis. Now, the most common adverse effect of NSAIDs are GI distress and bleeding. Also, in addition, as I said, prostaglandins are present in the postrenal arteriole, so be careful with pre-renal renal failure due to hypovolemia because you would not allow the kidney to compensate properly. So it could produce acute renal insufficiency. NSAIDs inhibit platelet aggregation and may increase bleeding. It could also produce fluid retention and peripheral edema if the patient goes into renal failure if you do not properly stop the medication while the patient is hypovolemic. Indomethacin is another NSAID that has a black box warning of depression and psychiatric disturbances, and COX-2 have a black box warning of it could increase heart attack or stroke. So many were already discontinued from the market. Tylenol, you need to remember Tylenol toxicity. Um, Basically, it could it can cause gastroenteritis within hours and hepatotoxicity 1 to 3 days after ingestion. There is severity of hepatotoxicity after a single acute overdose, and is predicted basically by acetaminophen level. Remember, the treatment of Tylenol toxicity is an acetylcysteine or mucomist. Now, in addition, NSAIDs could be given in patients that have any other autoimmune disease, such as rheumatoid arthritis, to reduce joint pain and swelling. Osteoarthritis as well is considered mild pain, and what you give is in the pain stepwise approach, Tylenol or NSAIDs. In gout, as we already explained, NSAIDs, colchicine, and steroids are the first line for acute gout, and in the NSAIDs lineage, basically indomethacin, naproxen, or Solindac you could use. So again, for mild to moderate pain, you have to use either Tylenol or NSAIDs. So it's a non-opioid analgesia. You could use ibuprofen, Advil, Aleve, naproxen, etc. For primary dysmenorrhea, basically menstrual pain, you could use NSAIDs, and that's the drug of choice. For tendonitis or bursitis, you could also use NSAIDs. For antipyretic purpose, you could use NSAIDs, which is ibuprofen, the drug of choice. Now, drugs to use for mild to moderate pain in pregnancy, Tylenol. If the patient has a history of GI bleed, Tylenol. If the patient has aspirin allergy or any blood dyscrasia or blood coagulation disorder, Tylenol. So drug of choice for fever, for adult children, as well as patients that are in pediatric population that have flu-like symptoms related to any upper respiratory infection. Remember, because aspirin could give them Ray's syndrome. NSAIDs, you have to monitor renal function because, again, if you do not allow the kidney to compensate properly, that could produce renal failure due to not allowing the kidney to compensate with hypovolemia. So also monitor CBC for any possibility of bleeding, occult blood as well in the stool. Monitor dosing for Tylenol because it could produce overdose and liver function. Take it as directed. Avoid alcohol consumption even more with Tylenol because it could produce more chances for hepatic necrosis. Report any GI upset. Now let's talk about aspirin and salicylates. They do have an analgesic, an anti-inflammatory, an antipyretic, and antiplatelet activity. Remember that the main mechanism of action is inhibition of cyclooxygenase and prostaglandin synthesis. Okay, so aspirin, irreversible, inhibit platelet aggregation, and the half-life is basically 7 days. So you must discontinue aspirin or any type of salicylate 7 days before any surgery or procedure. Is well absorbed by the stomach. Food will slow absorption, is well distributed in tissues, and is also metabolized in the liver. It does produce GI irritation and bleeding, mainly due to GI distress, microcytic hypochromic anemia due to iron deficiency anemia. At high levels, it could produce salicylate toxicity. And let's talk about that. Basically can cause vomiting, tinnitus. So whenever you hear tinnitus, ringing of the ears, and the patient is on aspirin, think about the possibility of salicylate toxicity. In addition, it could produce confusion, shortness of breath, hyperthermia, respiratory alkalosis, and even metabolic acidosis, and many multiple organ failures. The acute ingestion of 150 milligrams per kilogram of aspirin or any type of salicylate can cause severe toxicity. So basically, what happens is that salicylates impairs cellular respiration and they stimulate respiratory center in the medulla, causing primary respiratory alkalosis, and then simultaneously produces primary metabolic acidosis. It does disappear from the blood and enter the cells and poisons the mitochondria. So this produces lactic acidosis, and that's the reason why patients get metabolic acidosis, ketosis, fever, hypoglycemia, renal failure. That's another cause of metabolic acidosis, and to try to compensate hyperventilation. So patients that are children or adolescents with influenza, chickenpox, or any upper respiratory infection should not get aspirin because of Ray's syndrome. Avoid after surgery due to high risk of bleeding. Stop 7 days before. It's a category D. Never use it in pregnancy. I already discussed basically the salicylate toxicity. Lethal dose in adults is 10 to 30 grams. As a compensatory method, patients go into respiratory alkalosis. The treatment includes induction of emesis or gastric lavage if the patient is conscious, or remove any unabsorbed drug from the stomach if it's less than 2 hours from ingestion. Again, if the patient is conscious. If the patient is unconscious, you have to do hemodialysis. Charcoal, vomiting induction, gastric lavage is only done if the patient is conscious. You could alkalinize the urine by increased excretion, IV fluids, and sodium bicarbonate. Now, use it for fever, use it for mild to moderate pain, you could use it for rheumatoid arthritis, you could use it for osteoarthritis, or any acute rheumatic fever. In addition, it's used as part of the protocol for coronary syndrome in myocardial infarction. You could use a daily treatment from 81 milligrams to 325 milligrams of aspirin. For also transient ischemic attack, you could use aspirin. You could also, for monitor the levels, you could do salicylate levels randomly 7 to 10 days prior initiation therapy as baseline, or any type of possibility of toxicity symptom. Monitor renal function, because remember, it's an inhibitory of prostaglandin, could induce renal failure. CVC because of the possibility of bleeding, and fecal occult blood as well because of GI bleed. Take it with plenty of water and remain upright for 15 to 30 minutes because it could produce GI upset. Never crush. Try to always choose an enteric coated tablet. Sometimes the patients buy the oldest generation of aspirin and has like kind of like a vinegar like odor. Again, GI upset, bleeding, Ray's syndrome in patients, mostly pediatric and adolescent population that have flu-like symptoms, or chickenpox, or any type of upper respiratory infectious process. Never use aspirin. Osteoarthritis. So let's talk about osteoarthritis. Osteoarthritis is basically, if you recall, in pathophysiology, a chronic arthropathy characterized by disruption and potential loss of joint cartilage, including bone hypertrophy, osteophyte formation. The symptoms include gradually developing pain, aggravated or triggered by activity, stiffness lasting 30 minutes or less on awakening and also after inactivity, and occasional joint swelling. The diagnosis is basically by x-ray, and the treatment includes, besides control of pain, physical measures, rehab, education as well. So it's degeneration of cartilage by bone overgrowth. There's a breakdown of tissue leading to pain and joint stiffness on the hips, knees, also hands and spine. Um, First line treatment is Tylenol. Second line treatment is NSAIDs. Don't you never forget that. This is a highly topic of question. Osteoarthritis is considered mild pain, even though it could be progressively getting worse. But the first line of treatment is always Tylenol. Now, you could also use a second line NSAIDs. You could use aspirin, naproxen, or Solindac. You could use as well long lasting, such as Ralaphan, Feldan, or you could use COX-2 selective due to GI distress. To avoid that, Selecovix, Celebrex. Other pharmacological agents which are non-acetylide salicylate, these are diflunisal. Basically, it's useful for patients who are sensitive to GI irritation caused by prolonged aspirin use. In addition, you could use, when it becomes progressively more severe, the addition of opioids, which is a tramadol ultra, which is a category 3. But be very careful with patients that are opioid dependent, alcohol, so any abuse. Other pharmacological agents, uh, tapentadol, that are similar to opioids, that do provide an agonist mu opioid. The contraindications are pulmonary function is impaired. It could produce paralytic ileus and cannot be used within 14 days of monoamino oxidase inhibitors. Major side effects are dizziness, constipation, nausea, vomiting, respiratory depression. In addition, you could use capsaicin, which basically produces depletion of substance P, which is a pro-drug or cofactor of pain mechanism. You could use an over-the-counter patch, liquid or lotion. In addition, you could use diclofenac in cream, pills, or Voltaren gel. It works exactly the same as NSAIDs. In addition, for pain, you could use corticosteroids systemic, which is not recommended, or intra-articular, and basically depends on the size of the joint and the degree of inflammation. Now let's talk about rheumatoid arthritis. If you remember, it's a systemic inflammatory disease which manifests itself in multiple joints. It's an autoimmune disorder, primarily affects synovial membrane and produces erosion of the cartilage and bone, producing deformities. If you recall, you have the Swan-Ganz deformity. Basically, patients have joint involvement as well as laboratory serology is affected. There's a classification criteria for rheumatoid arthritis depending on the joint that is involved, and you could score the patient depending on severity. And also to clinically assure that the patient might have rheumatoid arthritis. So patients who have at least one joint and definitely clinical synovitis. If it's one large joint is 0, and you see that it will give you points. The more joints involved, the higher the number. Serology, if the rheumatoid factor is negative and anti-CCP is negative, then you give a 0. The more positive, the more numbers. If this C-reactive protein or serve rate is normal, you give a 0. If it's abnormal, you give a 1. And duration of symptoms, if it's less than 6 weeks, is 0. And if it's more than 6 weeks, is 1. So if the score is more than 6/10, then you need a definitive classification of rheumatoid arthritis, and the patient most likely has it. So the goal of treatment is to reduce pain and stiffness, and preserve mobility and joint function, because remember, these patients go into major disabilities. You could use salicylates or NSAIDs. You could use aspirin, which is basically the gold standard, but disease modifying anti-rheumatoid drugs are basically the first line, and it should be started as soon as you diagnose the patient, because it takes 3 months to work. So in people newly diagnosed of active rheumatoid arthritis, you should offer a combination of disease modifying anti-rheumatoid drugs that includes methotrexate and at least one of other DMARDs plus short-term glucocorticoid. That's the first line of treatment, and you should give it as soon as possible, ideally within 3 months of the onset of patient, because it takes a long time to work. Methotrexate basically is contraindicated in pregnancy. It's a category X. It's basically a chemotherapy. Black box warning is hepatotoxicity, bone marrow suppression, dermatological reactions, ulcerative colitis. It could produce hepatotoxicity, again, bone marrow suppression, so you have to check that. The DMARDs mostly used are sulfasalazine. As you could imagine, it has a sulfa drug, so patients that are allergic to sulfa should not take this medication, even though the mechanism of action is not well understood. Basically, the main way of functioning is by decreasing tumor necrosis factor and depleting or decreasing autoimmune reaction. Is orally administered. As I said, has a sulfa containing molecule, so you should not use it in patients that have sulfa allergies, as adverse drugs reaction could produce thrombocytopenia, agranulocytosis. You could also use anti-malaria drugs, which are hydrochloroquine, Plaquenil. You could use it in conjunction with methotrexate. Basically inhibits the antigen processing by elevating cellular pH and degeneration of antigen as well. So basically all of them work at the level of the immune system by decreasing all the factors of the inflammatory cascade, thromboxane, cyclooxygenase, prostaglandin, tumor necrosis factor. I apologize the interruption. So again, you could use it as the adjuvant for methotrexate. Uh, Basically, major contraindications are that antimalarial drugs could produce alteration of retina with retinal detachment, so you have to send the patients for ophthalmology evaluation. It could produce changes in pigment of the retina as well, so retinosis pigmentosa, photosensitivity, as well as neuropathies. It could decrease the metabolism of beta blockers, so you have to have that in mind if you have a patient with beta blockers, either for antiarrhythmics or for hypertension. Another DMARD is leflunomide, or RABA. It's an anti-inflammatory and an anti-proliferative action, and the same mechanism of action of methotrexate. The contraindications are basically pregnancy. There's a typical washout period for women who wish to get pregnant in 2 years. If there is any toxicity related to this medication, you could give, if the patient is conscious, activated charcoal or cholestyramine to reduce the half-life, and of course avoid alcohol. Another biological disease modifying anti-rheumatoid factors and tumor necrosis factors inhibitors, you could use etanercept, that Inflamax, as well as adalimumab, Humira. You could use Cimzia. These same medications are used for patients that have asthma. I don't know if you recall the stepwise approach of asthma, that when nothing works, you could use tumor necrosis factors inhibitors, which are really, really expensive and highly denied by the insurance. The main mechanism of action is to bind the circulating tumor necrosis factor, that is one of the pro-inflammatory mediators released, and also reducing interleukin. The contraindication, as you could imagine, is majorly infection and sepsis, so it could be fatal. Kineret and anakinra is also a recombinant of interleukin receptor antagonist, and basically what it does is interrupt the joint inflammation. So it's basically to compete with the inflammatory cascade. It does have highly sensitivity to E. coli, so patients could have an allergic reaction and hypersensitivity if there is a persisting infection. Another one, which is abatacept orencia, mechanism of action is more or less the same. It's decrease the activation of T cells and interleukins and tumor necrosis factor, and mainly the contraindication is infection. I know COPD patients, but it's basically any type of major acute infectious process. Tocilizumab, Actemra is again an interleukin receptor inhibitor, tumor necrosis factor inhibitor, decreases B and T cell activation. It's basically given by IV infusion, and contraindication again is an active infection, any type. So that's the end of this presentation for inflammatory conditions.